Since its publication in 1964, The Games People Play has become a surprise bestseller because it struck a responsive chord with its readers. Written for practicing analysts by psychiatrist Dr. Eric Berne, it explains in ordinary, understandable terms a startling theory of human relationships. Startling because of its simplicity. Dr. Berne's theory explains that the interplay between human beings can be understood in terms of the benefits that each receives. Called transactions, these games are one of several ways that we structure our relationships in order to keep our psychological distance from other people and prevent genuine intimacy. I'm David Prowett, science editor for National Educational Television. I visited Eric Berne at his home in Carmel on the California coast to discuss the applications of transactional analysis and the games people play.
Transactional analysis is a system of psychology for understanding human behavior, changing human behavior, and predicting human behavior.
Is a transaction the same as an interaction?
In some ways, we consider interaction to be a kind of a cowardly word because you don't commit yourself to anything by saying people are interacting. It's just a kind of a description. Transaction means that people are getting something out of it. Each person is getting something out of it, which goes back to the fundamental question of all social psychology, which is, why do people talk to each other?
What is the basic vocabulary that a layman needs to understand transactional analysis?
Basically, it's just 5 words. All of them, one of them has, 1 or 2 have 2 syllables, but they're very everyday words. Parent, adult, child, game, and script. Recently, we've added another word which is assuming more and more importance, and that's what we call a contract, which means people should know what they're doing to each other and what their jobs are in relation to each other.
Right, the parent, adult, and child are ego states. Would you explain what the other 2 are?
Well, a game is a stereotype pattern of behavior. That is, it's something people keep doing over and over, and they may do it for years and years, every day or all day, and they don't even realize that it's a stereotype pattern. They may feel that it's sort of something they just want to do, or that it's spontaneous, but it's something that comes out the same way all the time. And like, for instance, it may end in the person being angry or hurt or scared or feeling inadequate again and again throughout the day, and this is something which the person sets up. That's a game. Script is a lifelong plan. You might call it an unconscious life plan, which is decided in very early childhood, and if it's allowed to run its course, it will continue the way the person decided when they were 3, 4, or 5 years old, which is pretty young to make lifelong decisions, but that's the way life is. Actually, that's the way human beings are.
You really feel that the entire life is predestined from a script that's set that young?
Yes, unless something is done to change it. And I want to stress that because people get discouraged sometimes when I say that one's life course is determined by a decision that you make inside yourself at such an early age. But the point is, there are things that can be done to change that decision. One of them happens to be psychotherapy. There are other things. So it's not...
it's not irrevocable at that.
That's right.
Does transactional analysis have to be done in group therapy then?
Well, it's presented as a group method because groups are where lots of transactions take place, and it's very helpful in group therapy. What happens is that people who study it and try it out in groups generally end up using it in their individual therapy also because they see that it works pretty well, and most people use it throughout their practices after a while.
How widely is it spread in this country?
I think we have now 500 members in our association. It's spread widely enough so that we had to organize, much against our inclinations, because we don't believe in organizing things too highly. So there are about 500 members. I think we have members in about half the states of the Union. We also have a small branch in Costa Rica. We have some people in England. And recently, the most interesting development has been a branch in Hawaii, where it is being used.
As we've been talking, one thing has been bothering me. You talk about ego states, this parent-child and adult relationship. It sounds a little like a description of schizophrenia. Does it have any connection at all?
No, there isn't. What happened was that many years ago, in the early 1900s, somebody began to talk about split personality and related that to schizophrenia. But that was done in a very technical sense, which most people would find it hard to understand. But the expression got around, and then people began to think split personality means something bad. Actually, everybody has a split personality because every human being has at least 3 different people in his head.
It's a question of how well they're integrated.
That's right.
All right, well, let's get down to cases. What's the first thing that happens when a patient walks into your office?
First thing is to find out why he's there. What does he want? And then I try to see what I have to offer him. And that goes back to the word contract that I mentioned before. In other words, I want to know what he wants from me, what I can do for him, or what I can cure him of. And then after we've talked a while, he gets an idea of what I have to offer. And in that way we can come, we hope, to an agreement to go ahead with trying to help him.
I'm still not sure that I understand the term contract. Is every relationship between adults the establishing of a contract?
I would say so. I think a lot of trouble in the world comes from what we would call unclear contracts, which means people aren't sure how they relate to each other or what they're allowed to do or say to each other. And if they transgress these unspoken limits, there's very often trouble. So a clear contract, I think, helps in any relationship, and we feel, when I say we, I mean these other colleagues that we talked about a few minutes ago, we feel that the first thing in any treatment situation is a clear contract in the sense of what does the patient want and what can we do for him.
Can both of you understand this?
We should both understand very clearly about that.
Well, does the patient actually state his contract with you, or is this a conclusion you have to reach after talking with him?
Sometimes he is, sometimes he isn't, and at other times there's a third kind of people who come from, let's say, other kinds of therapy where they have a kind of contract which involves words that we don't like to use very much. They're sort of sentimental or unclear words like relationship, personality, dependency, and we don't really feel we know what they mean. So sometimes a patient will state what we call his side of the contract in those terms, like I want to have better relationships, and then we say, well, what is a relationship? And we finally try and boil it down to something very specific where we will know and he will know whether he is actually accomplishing what he set out to do in the treatment.
Since a contract is between 2 parties, does that mean that the analyst has to commit to the patient too?
Right.
You do feel that there is a commitment?
Yes, we have a very strong commitment to say we accept the patient's contract if he says it clearly enough. For instance, we may say, oh, then what you want to be cured of are migraine headaches. Well, let's see what we can do. And we may end up let's say that session by saying, okay, now you've had a chance to listen to me for a while, and that's the sort of thing I have to offer, so if you want to continue, fine, let's go.
Would you say that this is analogous to directive analysis, then, as opposed to non-directive?
Not really. I think all we're trying to do there is we're not trying to direct the patient. All we want to do is find out what the patient wants. Like sometimes I say, I'm running a psychiatry store, what do you want? Mm-hmm. And I don't think that's directive. I think it's direct, but not directive.
Transactional analysis seems to demand more from the patient than other forms of analysis. He really has to know his condition to make it work, doesn't he?
Yes, that is true. He has to find out what really goes wrong.
Not necessarily before he comes in.
No.
But he must know it before the analysis can begin.
That's right, because that's the only way we really will ever know whether we're accomplishing what he wants or what we started out to do, is if it's clear what we're supposed to be doing.
Do the patients really know that much about their case?
Bodily complaints are usually pretty clear. A migraine headache is something the patient knows he has, and he knows where it is, and then he knows all about it in great detail. But it's very easy to reduce many conditions to, let's say, physiology, which is very, very important. The body is really here to stay, and it is a very important part also of psychological functioning and psychological problems. For example, what people call trouble with relationships. If we really look into it, what he really means is, in physiological terms, something like when I go into a room where there are strange people, I feel funny. And then you say, where do you feel funny? And he may know very well, right in the pit of my stomach. And then we know that something in that situation is affecting his stomach. So that's what's got to be cured.
And he's actually getting a physiological reaction.
Right. There's always a physiological reaction to an emotional situation.
Well, I know that you believe in talking over the patient's illness with the patient. Is this generally accepted practice in analysis?
I think we carry it a little farther than most people. For example, one thing we've been doing lately is having the staff conference in the presence of the patient, even with adolescents. And it works very well. Most people, let's say most other clinicians, for instance, the hospital staff, are a little uneasy about it the first couple of times. But when they discover how beneficial it is to the patients and how the patients pull themselves together, no matter how disturbed they are ordinarily, if they're told this is a staff conference about you and it's your privilege to listen to it, it's amazing how, as we would say, their adult gets hooked, and no matter how oddly they were behaving before, they will sit quietly for an hour and listen very, very intelligently to an intelligent, open discussion of their own case.
You don't find that it frightens them in any way?
I've never known it to frighten them in my experience.
How do you translate the theories and the contracts you've made into a coherent plan for therapy?
Well, let's take as a sort of a theoretical example, a man who comes in and talks about relationships, and we discover what he really means is when he goes to a party where there are strangers, his stomach feels funny. Well, the first thing we do is talk about parent, adult, and child. In that case, it's very obvious that it's the child part of him that feels funny, because at an adult level or at an objective level, nobody at the party is going to hurt him or wants to hurt him. There's nothing to be afraid of. So then we trace that back and discover that is so. See, if we say something as your child, that's only our opinion. And in order to verify it, we have to go through certain procedures. One of them is to find out, did you really feel that way when you were actually a child? And if he did, then we say, well, our diagnosis is right. That's the child part of you. So it's very easy to trace back in such cases that the same thing happened when he went to kindergarten the first day or when he went to birthday parties. So we set up the child and the adult, and then it's a little more difficult, but not too difficult, to establish that it's something about the way his parents raised him which contributed to his child being scared in that situation. For instance, they may have been hammering at him, watch your manners, to take a very simple example. He goes to the party and he's scared that he may do something rude, then his parents would be angry at him, and then let's say all the other kids are going to have better manners than he has, and so they'll jump on him, and that scares him. So in that way, we set up the parent, adult, child first. Then the next step would be to talk about some of the transactions with other people, because those people who go to parties feeling frightened are somehow going to get themselves scared. If nobody goes out of their way to scare them, they'll set something up. They have to, as we would say, they have to collect a scared stand. So we find out by taking some examples, how does he go about having somebody scare him? And that's what we would call the transactions he goes through. And then if you add them all together, you have essentially a game, which in this case might be called Kick Me, in which he comes on so strongly, scared, as though saying, please don't kick me, that it's almost as though he were wearing a sweatshirt, and so we speak of sweatshirts. So a sweatshirt says, please don't kick me. Well, I think it would be interesting for somebody to actually put on a sweatshirt saying, please don't kick me, and go to a party and see what would happen. I think it's very obvious what would happen. Everybody would take a kick at him. So he gets himself kicked, and that's the game.
Dr. Berne, we've been talking about life plans as such. Just what are they?
That's where the word script comes in.